Hello, thank you for joining our symposium. You've heard from my colleagues about the perspectives of pediatric health and social work on the high-risk area of child maltreatment in Singapore. This sharing will be from the perspective of a perinatal infant mental health specialist, and we'll explore how we can strengthen the mother-infant dyadic relationship right from the beginning in the nursery. Just last year, this gruesome case shocked our local community. How could a mother kill her own child? These rare cases of filicide and infanticide are just the tip, and there exist many other cases of physical, sexual, and emotional abuse and neglect that have been surfacing now to the social services. I'm sure one common question that comes to mind is, are the women mentally unstable, or evil, or depressed? Or is it a combination of any of these? Let's take a step aside and look at maternal mental illness. This is indeed a public health concern here in Singapore, with 1 in 8 women having antenatal depression, by which we mean minor or major depression. And in 1 in 4 women, there will be postnatal depression. About 2% of women with postnatal depression will fulfill criteria for clinical depression, otherwise known as major depressive disorder. So with prevalence rates like this, we don't see the same rates of child maltreatment being reported, fortunately. So yes, clearly not all depressed mums are going to hurt their babies, but really, given the high rates of perinatal depression, there is an urgency for us to get it right for mums and the babies. The reason we need to act decisively is that the evidence is clear that perinatal depression has implications on a child's neurodevelopment. This even if maternal depressive symptoms are not severe. For our gastro cohort mothers were mostly in the moderate depressive score range. Prenatal maternal depression was found to cause microstructural changes in the amygdala, the brain region that's often considered the seat of emotion, implicated in the pathophysiology of mood and anxiety disorders. These changes are likely mediated via fetal stress programming, wherein the maternal stress response via cortisol changes and influences the fetal hypothalamic pituitary axis, which becomes imprinted with an altered set point. Here is another piece of evidence from a gastro cohort study that richly demonstrates these influences. When infants are exposed to psychosocial stress and deprivation, the primitive limbic pathways remain overactivated as the child has to respond with overdrive of the stress response. This depletes the resources and attention for higher order functioning and cortical development. In our sample, that's exactly what we saw, that there were lower frontal functional connectivity in the presence of maternal depression. And this in turn predicts for the resultant developmental trajectory towards an overdriven behavioral survival response at 6 and 18 months. These include aggression and externalizing behavior, and withdrawal and internalizing behavior. What this means is that a mother who is depressed may struggle not just with her own symptoms, but also the possibility that her child will have the neurodevelopmental footprints of her depression, which lead to behavioral disturbances that can result in greater tensions in the mother-child relationship. This creates then a vicious cycle that continues through the generations. In this American study of 2,000 mother-child pairs, Conran and his colleagues found that maternal depression increased by 2-fold the odds of psychological aggression towards children within a 12-month period. These included calling the child dumb or threatening to hit or send the child away. There was a non-significant association with physical aggression or neglect, likely due to the sample being small. So you would expect that something would be found if they replicated this in a bigger sample. In clinical experience, we see that mothers with depression often struggle with being emotionally attuned to baby's cues, or with the ability to tolerate infant negative states, and may perceive baby to be hostile or rejecting, as if baby could have an evil intent. Indeed, Sometimes this hostility to motherhood extends to psychotic proportions. Being with baby is so difficult that there is resultant avoidance. This happens then. Ill mothers are likely to poorly attend to or be sensitively attuned to the needs of their babies and little children. You see, what babies need most is the crucial empathic mirroring of a nurturing caregiver. It is through this that they will learn what joy is when mother delights with their inner burst of pleasure, or what fear is when mother scoops them in a secure cuddle and soothes their cries, or how to cope with anger when mother mirrors that emotion with a little less intensity that makes things just better and more tolerable. Or what's making you so cross? The thing is, it's really okay to be just a good enough mother. As Winnicott has famously said, because a perfect or good mother who is always attentive and responsive will not give her child the chance to have mastery over coping with frustrations of needs not met. Why is it that for some mothers, even being a good enough mother is so extraordinarily hard? Perhaps it's because of the past ghosts from the nursery, which Freiberg and Shapiro wrote about in this beautiful paper, highly recommended for those interested in the field of perinatal into mental health. Internalized hurts from long ago resurface, and these visitors and voices from the past are often abusive. Perhaps it's the voice of the father who abandoned the family, dismissing the worth of the children, or the voice of the mother who favored the firstborn son and neglected the daughter, or was critical and harsh. When we think about what these mothers could have in turn been affected by in their childhood by their grandparents, perhaps they were neglected too or cared for harshly, we then begin to understand how trauma can be transmitted through the generations because of the dysfunctional internal models or the internalized superego. Alicia Lieberman described the ghosts in the nursery as the suppressed parts of our lives, where we feel unresolvable fear and yet we're unable to turn to our parents to help us with those fears. The fears are transformed into self-protecting anger because we feel so much stronger when we are angry than when we are afraid. She described how children who are helpless need to find some place that they feel strong when they can't rely on their parents for assistance. And those patterns of transforming anger to fight fear get replayed with their own children later on. So when baby cries, a mother who herself had a traumatic childhood and whose needs were not met may experience the crying as something anxiety-provoking and may feel overwhelmed and avoid attending to baby. Or she may actually feel irritated and angry that the baby is purposely annoying her and smack the baby. How can we help mothers cope with the ghosts? Lieberman wisely put it simply, when we help mothers reconnect with long-forgotten feelings of being loved and protected, feeling wanted, we help create hope for them. They can use those memories as guides for themselves as they care for their children and to help them understand how they want to be with their children. So our task is to help them to remember the angels in their nursery who offer a positive model of how to love. Often it may be a kind aunt or grandparent or even a teacher. And if they cannot identify an angel or a green light, maybe we can help them create these through loving memories and loving moments with their children as we validate and affirm them in their developing maternal capacities. One of my patients who grew up with a narcissistic mother nurtured butterflies with her own daughters, and the wonderful memories helped to build mastery of her own mothering capacity. What is the role of the mental health professional then? In a nutshell, what I would advocate for isn't the removal of all scars or the morbidity or the symptoms, because therapy or treatment to resolve mummy's inner conflicts and illness will take time, and baby really needs us to work promptly. So the idea is about scaffolding a troubled dyadic relationship, sort of like building a net to cocoon the mother and baby dyad in a network of support. And all of us attending this lecture today who has an interest in doing this work can be part of the village that supports the mother in raising her child. Think of the dyadic relationship as the client and focus on strengthening it through building mother's capacity for reflective functioning. Help her make meaning of her experience. Help her think about baby's internal world. Help her think about her reactions and explore together how she can adapt in a way that feels better and works well for her. Each of us play an important role in helping to be her green light, her angel in the nursery, and every contact can be a touch point that shifts the trajectory for mother and babe in their life story. Now, this is a framework that we use with mothers on our service. Allow me to draw your attention to two of the items. The therapeutic use of self. Most of us come into our roles with a passion for caring and helping, and this is exactly what is powerful about the work we do. When you work with mothers who are at risk and have hurt their babies, it can be deeply unsettling to deal with the dysfunction in the mummy. So even as you allow yourself with apprehension to be the container, the wishful mother, always remember to work within the boundaries. And if you have had a particularly difficult case, take a moment to gather your calm after you are done. Thread a hand to heart, put your hand on your heart, and take a moment to have 3 deep, slow, calming breaths. And in that moment, you make a mental note to put aside the tensions you have absorbed. Another item is in mentalizing for baby. Mothers who have been themselves traumatized find it hard to think about baby's world because they feel so threatened that they project regressive impulses onto baby. A useful technique is to talk as if for baby to mum. So imagine yourself as the baby. You might try saying, "Hi, baby Mia. How are you? And how's mummy? She's really been trying hard to get it right for you this week, isn't it? Are you frightened when mummy is not herself? Is that why you cry?" So in that moment, when you say that to baby in front of mummy, you help mummy see just how powerful baby's mind can be and how she can talk to her baby. Lastly, I would like to encourage you all that the work we can do with mummy and babies can do a lot to lift them from their distress and illness. Even in mothers who suffer from psychosis in the postpartum period, a very grave illness with the highest of suicide risks. Sarah is a mother who suffered from current episodes after her 2 pregnancies, and there was a time she was afraid of her own baby, but with early intervention, she has come through with confidence and a strong bond with both her children. And with that, I thank you for your attention.